For our second panel, I would like to call Dr. Wu, Dr. Elliott, and Katie, and also introduce Dr. Christine Brezden-Masley, who is the Director of Oncology at Sinai Healthcare, and, as I said before, was my medical oncologist and angel when I went through my gastric cancer.
So there has been several questions coming in for surgery and medical oncology, but just to let everyone know, anyone is welcome to answer these questions based on their experiences. So the first question that we have here is from Shireen. So Shireen wants to know from Dr. Wu, have you ever constructed an intestinal pouch to aid in recovery? Any successes?
So personally, I think Shree's talking about after a total gastrectomy, the removal of the entire stomach, you can reconstruct, instead of just putting the jejunum up as like a tube, you can reconstruct a pouch called the jejunal pouch that connects to the esophagus. It's been often done in Europe, but I personally don't do it. The pouch does, in some trials in Europe, have shown that it does improve the ability to eat more and perhaps decrease dumping syndrome. So quality of life in the long run can be better. I just personally don't do that. And I do have certain patients that have dumping syndrome, but our dumping syndrome rate is extremely low after 3 months. And so I have not changed the method of my approach personally, but surgeons do that.
Thank you. We're getting a lot of questions about nutritional deficiencies. So, for example, Ware from Tennessee is asking, what can be done to boost iron levels after full gastrectomy? And Dr. Brezden, I know that you have a project that you've worked on and have been a very strong advocate for. What would you say about iron and other nutritional deficiencies post-gastrectomy?
Hi, thank you for inviting me today, and excellent presentations, excellent day. We have a project called Iron Gut, as we know that if you have had a total gastrectomy, the duodenum, which is a small intestine that comes right after the stomach, gets rerouted. It actually is removed. So as Dr. Wu would tell you, they perform a Roux-en-Y, which means they take the part of your feeding tube, the esophagus. You've seen lots of anatomy pictures today, and you've seen surgical pictures today, and it gets rerouted into the jejunum, which is the second part of the small intestine. So iron, if patients have had a total gastrectomy, they will not be able to fully absorb iron. And so we use a lot of intravenous iron. And we've demonstrated that many of our patients come in iron deficient. And in order to boost up their iron levels quickly, we give them intravenous iron. And we have a great product now. The trade name is monoferric, and it can be given 1 gram of iron over 1 hour. So it's a very short infusion and rapid repletion. In addition to iron, vitamin B12 is another important vitamin that is significantly affected in patients with stomach cancer. And so those are the two main elements that need to be repleted routinely, actually. So this is extremely important. The other pieces, and not so common now, and Dr. Wu can comment on this surgically, is that sometimes the spleen is removed with part of surgery. Now, that's become less and less, specifically with robotics, that patients are not undergoing splenectomy just by virtue of anatomy where the stomach is. And if the spleen is ever compromised or removed, then patients will need to be on antibiotics and prophylactic ones for that.
And Dr. Wu, do you have any comments on splenectomies?
Yeah, so there was the studies show to adequately remove lymph nodes that are positive or appear to be involved. we do need to remove those lymph nodes that are hiding in the splenic hilum. However, it shows that without that kind of positivity or a very specific subtype of cancer that is diffuse or involving the greater curve, splenectomy does not need to be performed. But surgery should not be different whether you do it openly or minimally invasively, whether you do it robotically or open. The reason for not removing the spleen or the lymph nodes should not be your approach. However, I do agree that there's less and less spleens being removed or distal pancreases because for some patients it does not benefit them, but increases mortality and morbidity of the cancer operation. So there is definitely less, I agree, less splenectomies, which is not necessary, but for certain patients, splenectomy to remove the hilum lymph nodes are necessary. So that's a discussion you need to have with your surgeon and the medical oncologist team.
Okay, great. And I actually just recently had an experience with intravenous iron. So for the longest time, so I'm 10 years out since a total gastrectomy, so 100% of my stomach was removed. And for 10 years, I've been anemic and I've had the hardest time with oral iron. There's a bunch of side effects, diarrhea, constipation that come with iron. Constipation would make me not be able to eat, which would cause more weight loss. I've been struggling with anemia for 10 years. And recently I've had 2 iron infusions and they've genuinely improved the quality of my life. I have so much more energy. I have color in my skin. I'm a much happier person, even in terms of my mental health. So it goes to show you that these little micro deficiencies that are often chalked up to a total gastrectomy, the impact that they have on your quality of life. So definitely speak to your oncology team or to your family medicine team to discuss those micro deficiencies because they really have an impact.
I think
we
this
have another
brings up
question. Sorry.
So I think it
Go
brings
ahead.
up a few really good points that when you have symptoms of fatigue and you're found to be anemic, you should check your vitamin B12 and iron levels. Sometimes we forget as physicians to check those for you. So as patients, you should ask for them to be checked to make sure that they're repleted and like you would have a response like yours when they're fixed.
Yeah, and we see that with many of our patients. So our intake now is on every GI cancer patient that comes into our clinic, we do full iron workup. And obviously vitamin B12 and folate, but typically it's the iron, and that's what usually brings the diagnosis, iron deficiency anemia. So, we need to certainly replete patients quickly. We can do that. We have intravenous iron and very well tolerated now, quickly given. And as you said, Katie, significant improvements in quality of life. We see our patients mentating better, more energy, better color. And we want patients to also get through the therapies they need to get through without having to delay them or reduce the dose. So it's extremely important in terms of supporting our patients.
And so I just wanted to add to that when I was diagnosed, I was incredibly low in iron and anemic, and Dr. Brezden's team recommended the iron infusions before my surgery, and then I had a couple of them throughout my treatment time. And it really does make a difference. It was, for me, I don't think they would have been able to do the surgery had I not got those iron infusions before my surgery was scheduled. So, and that was 10 years ago. So she was doing that back then. And I tell people always to ask, their team about checking iron. I still do. My levels seem to have been okay in the last little while, although I suffer from anemia constantly. But we always tell patients that ask us that they make sure that they do get checked both for the B12 and for the iron.
Great. Thank
May
you
I
so
say
much.
as well that from a psychiatric point of view, we test hemoglobin, iron, B12, because we don't want to be treating someone who appears to have a depression, whose symptoms are actually driven by low iron levels or low B12. With an antidepressant, they need B12 and iron. So not that we would be treating that, but we would be passing forward the information to the person who we're consulting for. It also, I just wanted to say that the previous speaker spoke about that, wondering about, is there the possibility for some sort of in-between clinic? And in the breast cancer population, as I'm sure the oncologists here are aware of, at least from Princess Margaret and I believe Sinai, at a certain point, women who have experienced breast cancer are moved to a in-between clinic, which is actually held at Women's College, where the focus is on the complications of breast cancer treatment, such as bone density and things like that. So there may be a place for that kind of clinic where you have GP oncologists, physician assistants, advanced practice nurses who develop a body of knowledge around the complications and protocols related to survivors of stomach cancer, who could really work with you. So just putting a plug in for that kind of rehabilitation model for cancer survivorship, even though from the moment of diagnosis for the balance of life, people are survivors, but that portion of cancer survivorship.
That is
Yes,
such.
so that's an excellent.
That's. Sorry, it's so important. We talk about the post 5 years quite a bit in our support groups, because people just feel like, what happens to me post 5 years? I mean, thank God I'm alive, especially, with gastric cancer having such, low rates of survival post 5 years. But there are a lot of us who do survive. So something like having that transition where you don't feel like you're abandoned. And I always tell this story that when when it came up for my 5 years, I said that Dr. Brezden was going to fire me. I was like arguing and fighting and battling it, because I'm like, where am I going to go? Who's going to take care of me in the over the next 5 to 10 years, when because I instinctively knew that the changes in my life would be forever. And we still get, there's the iron deficiency, and there's the fatigue, and there's still the issues with, with foods not sitting well. And really with stomach cancer, it's so lifelong, like with every cancer, but because it's that organ that, digests food and that. So boy, would sign me up for that transition place, because I think it would be amazing if we could do something like that as a place for people that have survived, the 5 years of stomach cancer, to not feel like they're abandoned, because in fact, some of the people do.
I think a survivorship program for all patients for their life after stomach cancer treatment is an absolutely necessary and an unmet need, especially most of our patients. As a surgeon, I'm very selfish about my patients. So once you're a patient, you're my patient for life. Unless you fire me, you are not fired. And you can come and see me for life, and you can come and see me often. And I think in that way, not just the surgeon, but a team, if you need it, so somebody to identify the issues for you and find the resources, whether it's the advocacy group or it's a clinic with physicians, a survivorship team. I think we should create one. because that's a resource that's lacking for most of our stomach cancer patients specifically. Whereas breast cancer, the high volume cancers like breast, lung, and colon, they have already developed those programs for our patients. We need to do that as well. I totally agree with everybody here.
So true.
Thanks.
Why do you think I begged Christine to be on our board of directors and our medical advisory board? I still needed to keep that connection. And she's, she didn't want to fire me, I don't think, anyway. But
Right.
I think here in Ontario, that is,
That's sort of,
medical
Yeah,
requirement.
we have guidelines with respect to our survivors, and so for I treat breast cancer too, and it's called the After Cancer Treatment Clinic, the ACT clinic, that Dr. Elliott was referring to at Women's College Hospital. It's a great clinic to refer patients to, but we are funded to see patients up to 3 years, and then that's it. And so patients are transitioned back to their family physicians, which I totally agree is challenging, but the volumes would be unsustainable. We have 5 to 7 new consults a week, sometimes that I see a week. And so this is the issues that we just don't have the capacity. So our healthy survivors, we discharge back to the family doctor.
So there are several surgical questions, and I'm sorry, Dr. Wu, to put you on the spot.
That's okay.
Dr. Brezden, maybe you can also help us with some of these questions. But two people on the chat actually asked very similar questions. So Jen and Jakub, they both asked about novel surgeries such as PIPEC and HIPEC. So they want to know when would you conduct either of those surgeries? And does Canada offer these surgeries or clinical trials for these surgeries?
So I don't know if Canada has a trial open in PIPEC, the pressurized intraperitoneal aerosolized chemotherapy. PIPEC is a novel, but HIPEC, the hyperthermic intraperitoneal chemotherapy method strategy, is not novel. It's been around for 30 years, actually. The reason it's not been so much applied in gastric cancer, it's used for other peritoneal carcinomatosis like colon cancer and appendiceal and ovarian. It's very well known in ovarian. The reason it's not been used in gastric cancer so much is that the drugs and the method haven't been super effective for HIPEC or intraperitoneal chemotherapy alone. That's why the approach, the PIPEC, the pressurized intraperitoneal chemotherapy, has been devised. It's just about the penetration and the delivery of the drug to kill the cancer cells in the peritoneum. Because the peritoneum has a barrier where IV chemo can't go to, this regionally directed therapy, or using both the intraperitoneal versus systemic therapy, is now being evaluated. And it also has to do with drugs. The drugs that we used in the past may not have been effective, but novel therapies are coming out and in combination. And we also are studying more the biology of this and immune responses. And so PIPEC is open in Europe and trials and used off trial, but in United States, it has not gotten FDA approval. So FDA approval is being thought after completing the phase 1 trial, which is to make sure it's safe to use. So I don't know that there is any PIPEC trial that's open in Canada at this point. There are 4 sites in the United States and numerous sites in Europe.
And
So
Dr.
I can
Brezden,
comment
I don't
on
know
that.
if you.
Yes, I can comment on the HIPEC. So Mount Sinai Hospital, where I practice, is a HIPEC site, and that we're the only HIPEC site in Ontario. But there's no treatment for gastric cancer. So gastric cancer, unfortunately, is not part of the Ontario HIPEC program. Now, that being said, we do have 3 other sites in Canada. So there's one in Montreal, there's one in Calgary, and there's one in Vancouver. So the 3 sites are where we send patients. And of course, it's biology. right? So
Yeah.
it's certain patients, very fit, and not a lot of, there's a score that's provided. And so patients have to have a laparoscopic assessment of their abdomen. So they have to have surgery just to take a look within the abdomen to see how much disease there is that can be actually treated with the hyperthermic intraperitoneal chemotherapy. PIPEC, I am not aware of any sites in Canada that are currently doing PIPEC with clinical trial, but it can be happening. I'm just not aware of it, which I think is exciting, especially with novel therapies in the peritoneum.
As excited, just one last thought about the regional therapy into the peritoneum, whether it's IP or HIPEC or PIPEC. We have to be very careful and very selective in offering these therapies with or without additional like surgery to remove the stomach and the peritoneum, because studies have shown that unless we can achieve a complete reduction, it doesn't benefit anybody, and it can be actually very harmful. So the selective indication, the patients that we want to do these for are a very small group of patients, unless we have novel agents that work better in the peritoneum. And so just keep in mind for those patients who are with peritoneal carcinomatosis, they can benefit, but I would take caution and have really it's a multidisciplinary. Surgeons can't do it on our own. We need the medical oncologist, and the medical oncologist and surgeons really need to discuss if it's right for you.
It's a lot of coordinated care.
Yes, it is.
Thank you. This is another question that's surgical. However, we have two sides of the coin here, myself and Teresa. So Dr. Wu, what are your thoughts of total versus partial gastrectomy, so the removal of the entire stomach versus some of the stomach, in terms of outcomes on survival and quality of life? And just to let you know, Teresa had a partial gastrectomy and I had a total gastrectomy. So you have two sides of the coin here.
Okay, so I think I touched upon it briefly on my presentation, but the decision for total versus partial, subtotal, distal, or proximal really depends on the location of the tumor. And patients who are able to undergo a partial really have the tumor located in one region, very distally usually. Proximal gastrectomies are really not performed unless it's an early cancer. For everyone else, you have a choice of a subtotal or a total. And if you have a tumor located in the mid-body or proximally, you need a total gastrectomy. The goal, it doesn't matter whether you have a total or a subtotal gastrectomy in terms of the survival. Studies have shown that as long as you can achieve negative margins, it's okay to have a remaining stomach, unless you're a CDH1 mutation patient or you're a high-risk patient to develop cancer in the stomach. You should have a functional preservation. For sure, patients who have subtotal distal gastrectomies, they do much better functionally. There's no doubt that total gastrectomy patients suffer much more quality of life issues, nutritional deficit, weight loss, than a subtotal gastrectomy patient. So preservation of the functional stomach is actually the secondary goal of surgery, and is very important. But oncologically, the principles are to get all of the cancer and any stomach that has cancer cells, the lymph nodes out. But whether it needs a subtotal or a distal or a total really it depends. The functionality of it is better if you just if you save some of the stomach, for sure.
Yeah. I mean, I think it's interesting that you talk about that, right? So Teresa and I, we always have this conversation about quality of life. So Teresa, I know that you've lost a significant amount of weight and you've struggled with regaining it, despite having a partial gastrectomy. Whereas with me, I did lose a lot of weight kind of at the beginning, but then I've slowly gained it almost all back to a healthy level. So it's interesting because intuitively you would think that Teresa would be able to gain weight more so than myself.
But there's also a reconstruction that helps you maintain weight and lose weight, or have, it's a balance between dumping syndrome, the Roux-en-Y that connects the esophagus. It depends on what your reconstruction is and how long that reconstruction is. You know, the longer the limb, the less the dumping syndrome, but more nutritional deficit, right? And also it depends on the connection between, is it narrowed or not narrowed? There's a lot of issues, but by and large, Teresa's probably on the minority of subtotal gastrectomy patients. And how much stomach is left, I'm not sure, but also will
20%.
affect whether you can eat 20%. And so, yes, it's almost impossible to gauge. My patients ask me this all the time, but I can't percentage the amount that's removed, really. The stomach does stretch, to get some more volume, but not that much.
And so the thing is I think I lost so much weight because prior to going into the surgery, I was actually overweight. So I think I went back to the way I was supposed to be in real life. But no, I've only gained back like 10 or 12 pounds in 10 years. And I had a really tough time in the first 2 years, but I'm at a healthy weight, and, you know, I'm really happy about that. But I actually do think that part of the reason I lost so much weight is because my eating completely changed, like off sugar, and I was barely eating anything. And I did have a lot of extra weight to lose. So I think that might, and so I think that that's probably the biggest reason why for me. And I've just never managed to gain back beyond 12 pounds, but I'm fine with that. I'm fine with that.
So I would like to ask one more question, and this is about positivity. So one person who wants to remain anonymous online said, as someone who is usually positive, after dealing with treatment for over a year and undergoing several life-changing procedures, I'm finding it harder and harder to remain positive and optimistic. What are some methods you can suggest to help with one's mental health and staying optimistic? So I think Teresa, Dr. Elliott, and perhaps our medical experts on the board can also weigh in on how to stay optimistic and positive during something so difficult.
I'll let Dr. Elliott start.
Thanks for that question. And, you know, you shouldn't feel a pressure to need to be positive all of the time. It is important to allow yourself to meet whatever experience you're having. And that said, if the arduous, enduring process of the past year has led to a place where you may now want to access a consultation to talk about what are the components that are causing this sense of not being your usual optimistic self. It's a change for whoever put the comment in. You're noticing a change. So it's always worth meeting with a healthcare provider with some expertise in psychosocial, psychological, psychiatric expertise to sort of talk that through and see if there are some additional supports that might be helpful to you. So there was a period of time many years ago where it was like, you've got to be positive or you won't survive. And that's not what we're talking about. But we are talking about there are ways to improve your quality of survivorship. And one of those is, like Dr. Wu was saying, to really access the whole team available to you.
Yeah.
And
I think for
from my
me, what's
perspective,
made me
go ahead, Katie, and then I'll talk.
sorry. I think for me,
It's okay.
what's been very important in staying positive and optimistic is actually my new role being a PA in GI medical oncology and seeing the growth that we've had this year in terms of immunotherapy and novel therapies, and even hearing Dr. Wu speak about the clinical trials that they are running in the States, and Dr. Alamova in the morning spoke about clinical trials in Canada. This is making me very optimistic that there are new things coming. Of course, maybe in the moment, it's hard for patients that are going through treatment to really stay optimistic with that in mind. But there is a lot coming, and that makes me optimistic.
I think for me, one of the things that I have learned over the years, and I still struggle with it, and I have to say that this year has been an incredibly difficult year for me, as I mentioned earlier, because of Lynch syndrome. I've been diagnosed with two other cancers and also gone through surgery. So I totally understand what this person is asking about. And I'm also the type of person that, wants to be in control. And I think for me, initially, especially in, the early days, the sense of that lack of control was really, really difficult for me. And I felt like my body was betraying me and there was nothing that I could do about it. And so it spiraled into a very, very dark place for me. I think what I have done over the years is learn to accept those moments when they're dark and to sit with them and be able to feel them in a way, but not get engrossed to them. You can feel negative or feel down, but make sure that that feeling doesn't overtake your life. And that's what I try to practice every day. For me, what gives me positivity is the fact that I can hopefully contribute and help others that are going through this, because when we were going through this, there was no one really that we could turn to. So for me, being able to help people, even if it's just to listen what they're going through, and offer some personal advice, like just personal based advice. But I think you really have to learn to accept those bad moments as well, and learn to sort of live in the moment, and know that it's going to get better, and that it's not always going to be like this. Definitely helps. And you just tend to learn how to become more positive. And I've had that challenge this year. And I've just said, nope, I'm just going to move forward. That's basically for me what does it. It's just about moving forward and being here every day and waking up every morning, because by normal means, I really shouldn't be here.
Thank you, Teresa.
I want to also echo, I really also want to echo what Dr. Elliott has said in terms of, finding support through your medical team. There are usually social workers, psychotherapists that can certainly help you, and really it's developing coping skills. It's a very, very challenging time for anybody with a cancer diagnosis, and stomach cancer is as I said, I treat breast cancer too. Stomach cancer is a very difficult cancer for anyone diagnosed. And obviously we're spending the day-to-day discussing this. And I do also want to echo what Katie said, is that I've been now treating stomach cancer for 17 years. And over the last decade, as you heard this morning from Dr. Alamova, is that there's so much research happening in stomach cancer. We are understanding stomach cancer much better. Biomarkers, you're hearing the oncolytic viruses treatment, all the novel therapies. So the hope, if I can just instill, there is such great hope for the future for our patients. And, you know, as a medical oncologist, we've seen this in breast cancer, cure the incurable. That is a big statement, but you know, there will come a day where we will have significant improvements in survival for our patients with metastatic stomach cancer. But the journey is long, and you can loop around if you can get that help through any team members on your medical team. Please reach out, because coping skills is a big part of being able to go through this journey.
So I like to share my tough surgeon love on this. Is I'm amazed when patients are able to be positive, because I think that this is a really tough fight. Okay, this is not an easy fight, and I don't expect anyone walking into my office to be in a positive, happy mood. Almost never, except after surgery, except after a cure, except after good news, for those short moments. But we know that this fight is going to be tough. And taking all the advice from everyone here, seeking help and trying hard is the thing that we can do. We can do our best as surgeons, medical oncologists, nutritionists, psychiatrists, the whole team of medical professionals. But the patient yourself have to put in your part. It's kind of like tough love. We do our part, you do your part. And to highlight what was just said is that I think we're going to cure stomach cancer within the next decade with novel therapies. Okay, maybe a new version would come, but with all of the advancements that we have, we need to bring those to stomach cancer patients, even the ones that already exist. If we can do that, we can improve patient outcome immediately. And with all the novel therapies coming up, there is hope. So how do some of my patients that I see stay positive? They surround themselves with love. They go exercise, and actually, they know that there is hope out there, and people who care, because we're here. If you need us, we're here.
Thank you so much to all our panel speakers. That is the conclusion of our second panel. We truly appreciate your insight.